Hi everyone, welcome to the NIHR Insight Engagement Programme for the West Midlands. The webinar today is presented by Coventry University. The webinar is to understand the 3 CoCreation framework with examples from practice and research. So I'll now hand over to our presenters to introduce themselves. Thank you.
Thank you, Alicia. Okay, I will just give me a moment while I share my screen. That's the wrong one. A second, I'm just trying to find the right presentation. It's not letting me share just my presentation. Sorry about this. We did do a tech test beforehand to make sure that it all worked, and now it's gone wrong. Bear with me. There we go. We got there at last. Sorry about that. So hello, as we said today, we're going to be talking about co-creation and the 3 Co's framework, and we will have some examples from practice and research for you. So today there's 4 speakers between us. There's myself, and I am a design manager and researcher at the Centre for Healthcare and Communities at Coventry University. We have Dr. Gemma Pearce, who is an associate professor in the same department as myself, and she's on annual leave this week, but she's very kindly done a video to contribute to the presentation. And then we have Dr. Helen Efkatari and Lucy Sylvester, who have used the 3 Co's framework in a clinical academic setting. So they will be sharing their experiences of using co-creation in research and practice. And hopefully once myself and Gemma have explained what co-creation is and a little bit of what it's about, they will share their examples, which will give you a bit of inspiration regarding how co-creation can be used in the real world. So today I'm going to give you an introduction to co-creation in healthcare research, and then Gemma will talk you through the 3 Co's framework, which is a way of using co-creation in research and practice, and then Helen and Lucy will discuss some clinical academic applications of the framework. So what is co-creation? It's not new. It's been around for a number of decades, but it is something that's increasingly being advocated to be used in the development of health and welfare policies, research and service development internationally. And very broadly, it's any act of collective creativity. So creativity that is shared by 2 or more people. And on this diagram here, you can see on the left, we have traditional research methods where you would have a researcher informed by theory, observing the user or patients from a distance. They go away, they analyse their findings, they write a report, and then they come back separately to share their insights with the world. In co-creation, and you can see the term co-design here, and we'll talk a little bit more later about the differences between the terms, but broadly co-creation is an umbrella approach and co-design is a specific instance of co-creation. In this co-design setting, we've got everyone together in one space. We'll have researchers, patients, users, and other people with a stake in the project that we're looking at, all using creative tools to design or develop or research something together. And why might we want to use co-creation instead of or alongside the more traditional social science methods that we might be more used to, such as interviews or focus groups? So traditional research methods can view participants as passive sources of data. So in the diagram on the previous slide, it's participants are being observed at a distance almost, and they're not active participants in our project. And sometimes these methods can also enforce traditional power structures, and it can be difficult to include a range of voices within one space. Even with the best facilitation in the world, sometimes in focus groups, we still have those more dominant voices and those people where it takes much more effort to try and get them to have the confidence to speak up in a group. And they also don't allow people to fully immerse themselves in a project or interact with whatever healthcare product or service, solution or research project that we might be redesigning or evaluating or researching. So why co-creation, and how can it address those limitations that we might have from other social science methods? It gives us the ability to more meaningfully involve people at the early stages of the design and research process and throughout, because there's a real focus and emphasis on involving people from the beginning of a project right through the end. And because we use creative methods, it allows people a space to play and explore the possibilities of the solution being developed, or the research project that we're looking at. We're not limited to just sort of one semi-structure question after the other. It's a bit more flexible than that. It's inclusive to a range of communication preferences. So traditional methods such as surveys require people to be able to fill in a questionnaire, whether that's paper-based or digitally, which can exclude some people. And focus groups and interviews rely on people being able to express themselves verbally. And not everyone has the ability to do that, the confidence to do that. If we use more creative tools in our research, we're giving people a variety of ways to feedback. They can scribble things down on post-it notes, they can build models, they can draw things, they can make a collage to express their thoughts and feelings. So it just opens it up to different ways of communicating with people. And because of that, we can include a wider range of perspectives on our project. There's also research to suggest that using more creative approaches to engage people in a research project can lead to the development of more original and innovative ideas, because it's accessing different parts of the brain that just asking people questions verbally doesn't always do. It can, not always, but it can save time, because we have the opportunity to get everybody in one space creating together. And if we have a range of people who might have a stake in a particular research project, say, for example, academics, patients, carers, family members, doctors, nurses, other allied health professionals, and using creative methods, it can really kind of start to break down those power structures and power barriers, and getting everyone working together to come up with some sort of improvement, depending on what we're looking at. It can also improve the match between what people need and what you get at the end of a product. So if you're doing research into a new healthcare service, there's an emphasis in co-creation around using those people who were involved in that service and will have a say and a stake in how that service works and whether it will be successful or not. So the earlier you involve those people, the better. So you're more likely to get an end product that works for people. And because of that, you reduce risk when actually launching the product or service or the results into the real world, because you've engaged the right people along the way. So you're more likely to have answers that work for people. When can we use co-creation? So I've talked a bit about using it in research as a research method, but it can also be used when we're doing patient and public involvement activities. So right at that beginning of the research process and throughout, and asking people what they want to get out of research and what their priorities are. And then I've also added that you can just use it for one-off meetings and smaller scale projects. So if you just want to have some sort of idea generation meeting, it's great to use co-creation methods in that setting, rather than just having people round a table with nothing to kind of inspire any creative thoughts and ideas. And if we're looking at the ladder of engagement, so this is a way of thinking about how we engage people in our research. There are different levels in terms of how we can do this. So right at the bottom, we've got educating people and coercing people to take part in our research. Hopefully nobody is doing the bottom rung, but this is when we're doing things to people and people are just passive recipients of a healthcare service or a research project, and they're not having any meaningful engagement in what we're doing and how it might affect them. And then as we move up the ladder, we can engage people, we can consult with them, we can inform them about things. So this is getting a bit better. We're starting to engage and involve people and seek their feedback. but it's at a relatively surface level compared to co-production and co-design, which is where co-creation fits in, where we're looking to do things with people in an equal and reciprocal partnership. So we're not just interviewing them and going away and analysing those results in isolation. We're really involving them in our data collection or our service development or whatever it is we're doing with our co-creation. So I've talked about how we want to involve the right people in co-creation. So who would you involve if you're thinking of using co-creation as a research method or a method to do some patient and public involvement? Really, you want to involve everybody who has a stake in your research, and that will change on a project by project basis. Some people might call these stakeholders because they have a stake in the project, but Gemma will talk later on about how sometimes that's not always the correct language. But the kinds of people you might want to co-create with are people with lived experience. So patients, carers, family members, advocacy groups, charities, support groups, healthcare professionals and clinical staff, doctors, nurses, midwives, allied health professionals, pharmacists, healthcare assistant support workers, researchers and academics, because they bring that academic knowledge and the theoretical knowledge behind a problem. Policy and decision makers, so the people who hold the money and make the decisions around what research gets funded or which healthcare services are commissioned. Technology and design experts, if it's something digital that you're looking at. So you might want to involve medical device and digital health companies or software developers, people with coding expertise, people who are good at user experience, so how people interact with screens and buttons and how digital products work. You can think about including wider community and support organisations, so local community leaders, local councils, social care services, charities, and industry partners and people with expertise on ethics. So this isn't an exhaustive list, and you don't have to include everyone on these lists, but it kind of shows the range of people that you can include when you're thinking about co-creating research or co-creating new healthcare services. So I keep talking about co-creation and doing it, but what does it actually look like? And I said that we prefer to use creative research methods instead of your more traditional methods, such as interviews and focus groups. So you might want to use collage with people. So this picture here is a collage I did with some older people and the wider stakeholders around them, technology companies, friends and family and charities in particular, and we asked them if what would get them more interested in investing in technology to support their healthcare needs as they get older. And they expressed these ideas through collage. So we have a picture sort of in the middle of a champagne glass. So they wanted healthcare technologies that would help them to celebrate their life, to go on holidays more. There's a picture of a radio there with a Union Jack flag. They were quite interested in having things that were locally made rather than some sort of random technology from Amazon or something like that. There's 5 stars in the top right hand corner there, so they wanted to be able to see product reviews and how many stars out of 5 that other people like them gave it. On the left, they said they wanted 5-year guarantees and they wanted it to be easy to use. So that's a nice visual representation of what older people wanted out of healthcare technologies. This here is some of our people on a co-creating wellbeing course, which I'll talk about in more detail in one of the next few slides. So this is some of our participants in that course, co-designing what the course will look like in the future. And again, they're using drawing and collage to kind of explore ideas creatively on how the course should look like based on their experiences. And this photo here represents sort of the variety of people that you can involve in co-creation. So here we have some older people, some academics and some healthcare practitioners and a technologist working together to design new technologies for older people. So it's about getting different people who maybe normally wouldn't work together to develop a new research project or healthcare service. They wouldn't normally be in the same room together, but it's about putting them in that room together and giving them the tools to have conversations to solve problems. Again, we used drawing. This was another technology to support older people. And if you see in the bottom right-hand corner there, we had people starting to explore what the name of the technology might be, and what the logo might look like. And Lego is something that you can use, and we've used before in our co-creation. So this is some people here using Lego to use metaphors through building to explore. Again, this is the development of a co-creation course. And another example of Lego is one of our students who used it to communicate with some housing association tenants. They worked for a housing charity, and they wanted to have conversations with their tenants around the security of their housing and what makes people feel more secure at home and what they wanted to have in their homes to make them feel more secure. And they did this through using Lego models to represent the housing and the tenants and the staff. And the feedback we got from that was that this was a really useful way of communicating with their tenants, many of whom aren't particularly verbal. They have a lot of people who are neurodivergent and have autism, and aren't always particularly verbal. So sometimes like an interview or a focus setting wouldn't work with them. But in that group of people, using Lego to kind of facilitate conversations really helped. So that's why we do it, and very quickly what it might look like. And if anyone's sitting there thinking, okay, this looks interesting and I'd like to maybe have a go, how do you do it? Well, myself and Dr. Gemma Pierce, who you'll see in a video coming up soon, we worked on an Erasmus Plus funded project called the Co-Creating Wellbeing Project. And this project asked us, plus our colleagues from a number of European countries, Portugal, Denmark, Italy, and France, to develop a curriculum to help develop skills to apply co-creation in the real world, particularly for people working in health, education, welfare, sport, youth, and social services. So we've developed a curriculum, we've ran a number of pilot studies, and the funding has just come to an end. And at the end of the project, we really wanted to be able to share the curriculum with people and share our top tips and resources on how to do co-creation with people. We didn't just want to end the project and not share what we had learned. So if you visit this website, the Co-Creating Wellbeing website, you can see the resources that we've shared. So on the left here, we have co-creation tools. So if you're interested in how can I use collage in my research, how can I use Lego in my research, and we have lots of different examples of tools that you can use. And we have an online handbook which has some examples and some how-tos of those different activities that you can do. And you can see on the right hand side here, we also have some videos just giving people some top tips on how to think about starting to incorporate co-creation into their research and service development work. And as we're coming from this from an academic point of view as well, a lot of people might be thinking, well, what kind of framework can I use to guide my co-creation work? And the Co-Creating Wellbeing was a follow-on project from a previous project called Co-Creating Welfare. And from that, my colleagues Gemma Pierce and Paul McGee came up with this 3 Co's framework to guide the co-creation process. And it's a 3-stage process. There's a stage of co-defining, co-designing, and co-refining. And we'll move on to the next slide, which will be my colleague Gemma, and she will talk you through the 3 Co's framework and a paper that they've recently had published, giving more information on this. So hopefully if I play this, you should be able to hear. Can someone please let me know if you don't hear the sound, but it should work.
Hi, I'm Dr. Gemma Pierce, and I'm going to be presenting to you about the 3 Co's framework paper that was published by myself and Paul McGee in 2024. And it also has some key solutions that were identified to challenges and top tips reflections. So the 3 Co's framework is the first bit of the paper. And you've got the 3 Co's, so co-define, co-design, and co-refine. The first bit is really your conceptualization, identifying the needs and who will be coming along as the people involved in the co-creation process. Looking at identifying what key challenges you might face and the problems through problem formulation, and then identifying what resources different people bring and managing any conflicts that come up. Thinking about how you're going to engage together is a really key one, and also things like ownership of what you're going to be co-creating. The co-design process is looking at what you want to solve in terms of the problems that were identified, and co-designing those solutions together, and looking at how to make those actions implementable. So who is going to be responsible for the production of those outputs or output. And then the co-refine process is looking at what has been created. So if there's been a prototype or an idea that's been put together, and then thinking about that iterative development further, and then thinking about how to disseminate and create impact in a sustainable way long term. So additionally, we had 5 key challenges identified from the co-creation that we carried out. And it looked at who should be involved and what should they be called, and is it really about empowerment or is it something else? There was issues with management wanting to have more traditional methods and not liking the co-creation method for some people. And what happens if you want to do it past a local face-to-face context, and how do you evaluate it? In terms of who were involved, so the first thing was is that it's not just about professionals and end users, because that's very us versus them. So it's more than that. It's anyone that could be involved and create a barrier or a success for it moving forward. So that could involve a commissioner or a service deliverer or the management. And people didn't like the terms stakeholders, citizens, or people because they're too generic. Who are they? And so actually they said we prefer the term co-creators. And so on to empowerment. So this was really interesting because people originally thought, well, obviously it's about empowerment. But then the more they went through, the more they thought, actually, it's not, because empowerment makes it sound like someone is giving someone else power. And that's not what we want it to be about. So actually, it was more about creating a space, because the co-creators, they already have power. So it's for them to be able to harness that power and express their voice. In terms of management buy-in, the solution to this was more around finding the terminology that the management could understand and align with, and thinking about the priorities and their process and how the co-creation process might align with that. If you're doing a traditional approach, it might be that it's really quick to do straight away, but it might not be very successful because you haven't talked to the key people. So people might not turn up, or it might not be commissioned. So actually the co-creation process, although it takes a little bit longer to set up in the beginning, it might actually be more efficient long term because it will actually be more likely to be successful. In terms of broadening co-creation, so first of all, a pass the parcel method was developed. The idea is that you might have different groups in different places, and one group looks at it and then passes that idea on, and then passes it on to someone else, and then you're passing the parcel. With the idea that people aren't precious over their ideas and they're happy to pass them on. And the other thing around this was around the online methods can be quite useful for doing it with, if you're looking at national, international context, or people with different needs that may need to be online. And so that was one of the reasons why we actually developed this co-creating wellbeing project, in order to look at that use of online, or a mixture of online and face-to-face co-creation methods. And another thing that we wanted to look at in co-creation was the thing that had been brought up about how you evaluate it. And so that's another part of the co-creating wellbeing project. And so you can see here, this is the how evaluation is embedded within the 3 COs framework. But it's important to really think about what that co-evaluation is going to be throughout the process, and really thinking about that at the co-define phase at the beginning. and evaluation can be done throughout the process as well as at the end. So that's worth bearing in mind. And some key top tips. So I'm going to go through, so there's 4 top tips here. So we've got facilitating. So the key thing about facilitating was, because it's participatory action research, it was often that actually the person that was initiating the co-creation actually wanted to be involved in the co-creation, or they had some sort of stake in it, and that's why they were developing it in the first place. So one of the things that we were discussing is, can they actually be a co-creator as well? And the conclusion was yes, they can if they want to be, but this really needs to be discussed and defined at the beginning with all the other co-creators. Is it that they are going to be really heavily involved in the co-creation activities, and therefore maybe the facilitation should therefore be divvied up across everyone that's involved, so it's not just one person doing it and it spreads out that power? Or is it that that co-creator is involved in a way that they are facilitating the activities and they are responsible for the co-production of the outputs agreed and then going back to them for the co-refine process? Or should they just not be involved at all, and are they just purely a facilitator looking from the outside? And that co-creation group is therefore really important for them to think about how they're going to create something that's sustainable, and they need to take on that responsibility fully. In terms of a co-creation setting, it was actually agreed that a neutral setting was quite important to consider, if possible. So not necessarily being hosted in a professional setting or an academic setting, and actually thinking about, is there somewhere more neutral that could be hosted to reduce that us versus them feeling? Now, that's not always possible. Sometimes you just need to get the free space that you can use, or, you know, actually it's really difficult to get hold of one group of people, so you need to host it in their setting. But that should be explicitly discussed from the beginning, and maybe there's ways that within that setting you can look to be more creative, so making use of more fun or creative or outdoor green spaces, and also thinking about potentially the use of some online dialogue as well. In terms of group dynamics, it's really important to discuss this right in the beginning stage in your code define, thinking about how people want to engage with each other. And sometimes you have people join or leave halfway through, and then that consideration about how you're going to engage needs to be rediscussed. So thinking about those dynamics and those changes over time. But this is where it's really important to discuss things like ownership and IP, as well as who will take responsibility, and how the different people are involved in what different roles. And then this leads to that responsibility for sustainability. And often what happened was people were doing a co-creation process, and then if they were the facilitator, it was being left up to them, because people just assumed, okay, well, we've told you our part, now you go and make it. But actually that could be quite off-putting if you don't have the time or capacity to actually do that. So it's really important right from the sort of earlier stages to really think about who has that responsibility to make those implementable actions actually happen and keep the process going and the outputs happening. So that's really it from me, talking about the 3 COs framework of co-define, co-design and co-refine, and thinking about some of the key solutions and reflections that we've had when doing these co-creation processes. And if you want more information, please do read the paper and have a look at our Co-Creating Wellbeing website. Thank you.
Okay, let's move on. So that was just a summary from Gemma on the 3 COs framework and how that can help frame any co-creation work that you do within research or practice. So given that, let's move on to seeing how 2 different people have used the 3 COs framework in the real world for their research. So first up, we have Helen, who started her clinical academic journey by doing an NIHR MRes at Coventry University, and then went on to apply co-creation within a successful PhD fellowship with the British Heart Foundation. So I will now pass you on to Helen to talk about her work.
Thank you very much, Nikki. So as Nikki said, my name is Helen Neftahari, and I've just finished a PhD where I looked at co-creating intervention for people with a health condition called postural orthostatic tachycardia syndrome, and POTS for short. I think what's important about the intervention is that this was driven by my own clinical practice as an arrhythmia and syncope nurse, seeing people with this condition, and having for many years supported people in self-management with lots of different types of cardiac conditions. I'm thinking to myself, how would this look like for people with POTS? So I won't tell you too much about POTS. Nikki, next slide. I'll talk a little bit about the methodology I used, because I think this was quite important in terms of framing the use of the 3 COs framework. So I looked at complex intervention framework. A lot of healthcare is in keeping with complex intervention framework. It was updated by the MRC and Skivington et al. In I think it was 2021, and also in 2024. So the developmental phases that I looked at, there were 3 phases, and my research was a mixed method sequential 3-phase design. The phase 1 was developing the evidence base, and this I did with the with qualitative study. The second phase was intervention development, and the third phase was the feasibility of the study. So I'm going to mostly focus on here the developing the evidence, and the intervention development, and how I integrated 3 COs into this. And then if you want to ask any questions at the end, I'm happy to answer them in terms of other aspects of the research. Nikki? So how did I apply 3 COs framework? Well, if you think of the phases of the research design I did, the first phase really fits quite nicely in the 3 COs with co-defining the issue. So I undertook a qualitative study, and I identified different components that were potentially applicable to a supportive self-management application, and developed a conceptual model of experiences and self-efficacy enablers and barriers for this patient group. Following the code, and this is quite different to the original application I think that Gemma spoke about, which was around people meeting together. And like I said, specifically for this one, I undertook quite a large qualitative study, which I'll talk about in a minute. The second of the 3 COs that I used was co-designing the solution, and I undertook this in phase 2 of the research design, which was the workshop. So there was a workshop 1, which was co-designing the solution, to prioritise what would be the specific components that you would see in a supportive self-management intervention. And then then I undertook a second workshop, which co-refined the solution. So we'd looked at prototype designing in between the 2 workshops and designed a solution. And what was really important across the research was that all aspects of this as a follow-through and engagement was I had a public and patient advisory group that looked at various different findings that I had, helped run the workshops, that really helped ground this research as a co-creation study. Nikki? So in the phase 1 of co-defining the issues, I undertook a qualitative study which had a large number of people with POTS, 19, and health professionals, 25, and these were in-depth interviews. So I won't go through all the findings of that because of time here. But there were basically 4 themes that emerged out of that, which was that POTS is a challenging condition for both clinicians and health and people to live with. That POTS services are by accident and not design, and that proved a number of issues for people with POTS access in healthcare and also health professionals in terms of delivery of care. The need for validation, and that was for both sets of interviewees, and the need for validation is quite important in terms of then the follow through of what I did in the supportive self-management intervention development. And then in the 4th theme was the practical self-help, that everybody really needs a hand to get going in supportive self-management, whether it's a lot or a little, but some pointers to get you in the right directions. Nikki? From the original qualitative study, that I have to say as well that the themes were discussed through with the PPI to group to see if there was resonance of the themes and stuff and things like that while we were doing the analysis. And then specifically out of the qualitative data, we looked at co-defining what the issues were. So we took out the qualitative data, specifically that were within the interviews for supportive self-management. And we mapped it to a taxonomy, so the PRISMS taxonomy, and these have this taxonomy has 14 components of potential supportive self-management. Not all of them came out in the interviews, but quite a number of them did. And you can see there, again, I won't go through all the details, but there were a number of different aspects to supportive self-management that people brought out. So these were the co-defining the issues about what sort of support people might need in a self-management intervention. Nikki? So, excuse me. So what we did then was co-designing a solution. And I worked with the PPI group, and we planned and two members of the group facilitated workshops. So the first workshop was co-designing a solution. This took place in 2023. And this involved both people with POTS that were recruited via the POTS UK charity and also health professionals. People were paid, and the people who were interviewed were paid in accordance with NIHR PPI involvement activities. And the way we ran the workshop was we had introductions and the research was explained. So the introductions, the facilitators from the POTS PPI board undertook the facilitation of the workshops, introduced the workshop, and then I went on to explain the research and the taxonomy. And then people thought about their silently generated their priorities based on this, the taxonomy and the data mapping that undertaken previously. And then we used something called a nominal technique where participants then went round and shared 1 point each that they thought was important and why they thought it was important. And then the next person would then share a different priority that they thought. And then we did this in a round robin technique, go around each person to find out what things they thought were important until all potential priorities were identified. So let's say in the first round, the workshop had 11 people in it. So let's say in the first round, all 11 people had a priority that they spoke about. In the second round, you may only find 4 people had said, what their priority was. And we kept going round until everybody had identified a priority. Then what we did was we explored the priorities. We broke into 3 different breakout rooms and people explored why they thought different priorities should take place over other ones. And then we came back, shared the different discussions, and each person anonymously voted for their top 5 priorities. And then through the voting, we did a scoring system whereby your top priority received 5 points, your second priority received 4 points, and so on and so forth. Nikki? So this is not quite okay. So this is the priorities that were set in the workshop, and you can see there were a total of 13 from that original taxonomy that were discussed and thought were important. The top one was knowledge and understanding of the condition. Validation of experiences came next, which again really emphasized the importance of that co-defining stage when we looked at the interviews and that whole theme that came out around validation. Communicating about POTS with social networks, POTS lifestyle, reliable resources and information, psychological support, how to manage flares, understanding the potential debilitating nature of POTS as a variable condition that's invisible, that doesn't have a quick fix, and then a number of other ones that came through as well. Nikki? So then what happened was, after the workshop, I went away and developed a prototype intervention, and discussed it with the PPI board. So the two facilitators that had been part of the workshops also fed back, and that sort of helped ground me in the discussions that had been taken place in the workshop. You know, a number of pair of ears is always better than one pair of ears. And then about 2 weeks before a second workshop was planned, the prototype intervention was sent to participants. Again, they were paid for 2 hours in order to review the intervention. Nikki? From there, we then went and we co-refined the prototype intervention. So people went through, and, you know, I think it was really important because people were very aware that I'd developed the intervention and what I was doing. So just to give people permission, actually, it was okay to kind of tear it up if they wanted to and tear it apart. Generally they didn't, which was good for me because it didn't have as much work, but it was really important because people emphasized what was good about and accessible about the intervention in terms of layout, formats, the different components, the deliveries, and what the supportive mechanisms, and then what were areas that needed refining. And a lot of the refinements actually were quite simple, around sort of like bringing something in about using different learning styles, visual aids, using different types of summary boxes, just to make everything more sharper and clearer for people who are using the intervention. And then looking at there were a number of different ones. One of the biggest ones actually was that we discussed about having a document about how to be a facilitator, because the intervention itself relied on having facilitators delivering it, that had been trained up by myself as the intervention developer, and the group felt very much so that the facilitators would needed to be supported in that with a facilitator manual. And I worked with the PPI group in terms of developing the facilitator manual from there. So that was our co-refining stage. Nikki? So then there were further co-refinements, and I think that's really important, like that whole process that you go through. It's not a wooden cycle. You'd go from one stage to the next stage to the next stage, but that it's very fluid in terms of how you look at co-refining and requiring multiple iterations, really. So then after we did that initial co-refinement, I went back to the PPI board, and what we helped refine further was the facilitator's guide, an animation that was part of the intervention branding, and also we decided on our outcomes through the PPI work, to get outcomes that were applicable to this patient population. And we came out with 4 sessions within the intervention that were delivered over 2 hours, with multiple micro breaks in it, as suggested by the PPI and the workshop work. So in the first intervention was education about the condition. Second session was information about lifestyle as the cornerstone management and how to manage flare-ups. The third session involved psychological support, and that was really important. It was more about recognizing the condition as needing psychological adjustment, rather than what came out in the interviews was a lot of people were often told they were mad or suffering from hysteria, because this is a predominantly female condition. So it's really important to get that approach to need for support for psychological adjustment, right, that you weren't sort of like reinforcing for people that this is all in their heads, and communication with social networks. Through the delivery with trained facilitators, This one, we use that as validation of the POTS experience, because validation came out so high within the interview study. Again, it came out really important within the workshops. It was the second above everything else. It came second in the nominal voting process. And so by having facilitators that re-emphasize that everyone's experiences are different, but actually that's okay, and it's okay, your experiences, those are valid, was really important. And having reliable resources was one of the priority components, and that was woven into the intervention itself, and the types of videos that we used. Nikki? So the one important thing I just want to mention, I'm not going to go through this all, but the complex intervention framework for healthcare interventions identifies the importance of having logic models to understand why interventions work, under what context, what are the inner mediators that we can potentially influence within interventions, things like, for us it was validation, reflection, self-efficacy, that there can be outer mediators that you really don't have any control over in interventions, and to get an understanding about where this intervention might apply, actually using that co-defining stage, where those interviews and the co-designing stage, where all that information was brought together about where this intervention can impact, and then what things are beyond really the control of the intervention itself. And it fed in quite nicely in terms of having undertaken that co-designing work, and framing it within the 3 codes really helped with developing a logic model for the intervention. Nikki? So I think I'll leave it at there, because I think I've probably said enough for the time being, but I want to acknowledge my supervisory team across the PhD project, the charities, the Public and Patient Advisory Board, all of the research participants from the interviews through the workshops, particularly the facilitators of the intervention, who were absolutely invaluable, and other parts of the networks that I was involved in. Thank you.
Thank you so much, Helen. So now we have another application of co-creation, and this is from Lucy, who is currently using co-creation within her NIHR doctoral clinical academic fellowship, and she is examining rehabilitation for people with complex fractures after traumatic injury. So over to you, Lucy.
Thank you. Hope everyone can hear me. I'm going to turn my camera off because I think my internet might be a bit unstable, and someone else has written that in the chat, but hopefully you'll hear me okay. Yeah, next slide, please. So I was just asked to talk a bit about my clinical academic journey to get here, and then obviously my current study and the 3 codes framework, and how I've used co-creation in practice. Next slide. So just a little bit, I'm not going to go into detail, but I'm a physiotherapist by background. I qualified in 1998, progressed relatively quickly up to a band 7, and then came to that point of what do I do from here. That's the stage where I started to look at MSCs, and actually did one in health services management. And that led on to other opportunities in going ultimately into a consultant physio role where I used to work in London. And the reason I'm saying that is just that being in that role and being involved in a number of national guidelines all inform my current research question, which has very much been based on clinical practice and what people and patients and public that I've worked with for many, many years have said is a gap in their service provision. So my particular area of interest is in major trauma or traumatic injury, particularly those people who have complex musculoskeletal injuries and complex fractures after road traffic collisions, falls, assaults, any sort of mechanism of injury like that. So I worked for a long time trying to improve things through clinical practice, service improvement, but I was just very much aware that my research pillar was weak. And then just made a life choice in 2018 to move to Warwickshire and started working at University Hospital Coventry. And that's where I met one of my current supervisors, who encouraged me to do the West Midlands pre-doctoral bridging programme, which is a fantastic opportunity that brought me out a day a week to prepare my DCAF application, which I submitted and then luckily was successful and started that in April 2023. So I'm just about to start the third and last year of my PhD. Next slide, please. So this, I'm sure with the audience on this, you're all very familiar with this, but just to give you an idea of the pathway. So I'm currently on the doctoral fellowship, and they're changing the terminology a bit to bring them all under that sort of doctoral fellowship or advanced fellowship title of the awards. But it does give people amazing opportunities to both do research, but also to develop your skills. And you have a training and development plan as part of the fellowship, of which part of that for me has been involved in the co-creation course and qualitative research methods in order to do my project. Next slide, please. So moving on to my project. So as I said, my background's physio, and for many years I've worked with people who've had complex fractures, and there's a real gap in the rehabilitation offered to people in this area. So my project is to develop a rehab programme, and similar to Helen, using the Medical Research Council framework for complex interventions, and using a partnership approach. So very much involving, as we've been talking about with co-creation, the people who receive the intervention or deliver the intervention or commission the intervention. So they're involved throughout the whole research project. So this is my study. So the co-design part was partly done prior to me starting my PhD, and then has obviously continued. So there was a James Lind Alliance Priority Setting Partnership, which you may or may not have heard of. But again, people who are stakeholders or have a vested interest came up with their priorities for research, of which one was what is the optimum outpatient rehabilitation program after complex fractures, which led into obviously my fellowship question. There's also been clinical practice and clinical guidelines, and I did a previous small research project interviewing people again to get their experience of rehabilitation. And throughout this work, similar to Helen, I've had patient and public involvement activities, and so I've got 3 patient partners who have been involved right from the application process and continue to be involved throughout my PhD and hopefully beyond. So my first work package was a scoping review, so looking at all the evidence and the literature, and then my second work package was qualitative interviews. And both of these 2 packages have then informed the one that I'm currently doing, which is the intervention development workshops, where I'm co-designing and co-refining the intervention to then test. Thank you. So co-creation in practice, this is the main bit really. So my patient partners, I said, have been involved throughout the project, and that's been in multiple ways. But for example, they've helped develop the recruitment strategy. So who I recruit, how I recruit them, what information I give them, checking how I've written the information, is it clear, and not just having a long participant information sheet, but like a short read version with most of the salient points on it. They changed my data collection methods. Originally, for example, rather than doing interviews, I was going to do focus groups, but they thought interviews would be much better and allow people the space to talk and share their views. They developed the topic guides that I used for the interviews. We did mock interviews, and then that dramatically changed the topic guides and the wording I use. So they're just some examples, but they've been heavily involved throughout the project and will continue to be so. The recruitment strategy, similar to what Gemma was saying in her presentation you heard, but the key was to include a range of people right from the start who could either be a barrier or success to implementation of the intervention that I'm trying to design. So for my project, I had people with lived experience, I had healthcare professionals that work regularly with this population, and I had commissioners or service managers that have to deliver the intervention in practice. So we had all those voices in the room. And then for the co-creation workshops, I'm running 2. So the first one was in person, which I've done. And then the co-refine workshop is online, which is actually tomorrow. So just talking about the first workshop, it was a neutral and convenient setting. So I was lucky with funding to be able to use a setting in central Birmingham that people could get to very easily. I did a visit to make sure it was totally accessible. They did catering, so everyone was well fed and looked after. And I think that made a real difference in making everyone very relaxed. Nikki talked a bit about or Gemma and her talk about the roles of the team. So we decided that myself and Gemma Pierce, who's one of my supervisors, would be a facilitator, but the other researchers or supervisors in my team would be co-creators and join the group. So those roles were defined. And then we did how we'd like to engage with each other to make sure everyone felt free and understood how they wanted to interact with each other. We did a story cubes activity, which was the icebreaker. And then we did a stimulus activity, which is where we use quotes to stimulate discussion, to address some of the key uncertainties we'd found from the previous interviews and literature. And then we did a carousel activity, which is where people had stations and each group would go around and keep adding to each other's work. And then we discussed it all at the end. And out of all that, we created artifacts. So there was lots of flip charts, there was lots of posters, there was lots of coloured pens, and each group created a poster which could be as visual or creative as they liked to share their messages when they fed back to the group. And those artifacts also obviously gave me something to take away and analyse and code for my data analysis. So just, I'm aware of the time, but just say the experience was really, really positive. And it's the first time I've used co-creation. And I think everyone in the room, no one really spoke about their roles. Everyone really did have an even voice. And you could see the interactions, you could see the general chatter in the group, and everyone actively participated. And it really did remove those sort of power structures or boundaries you sometimes see when you bring professionals and the public together. And I did feel that the creative methods really help people to feel engaged and immersed in the process.
Thank
Thanks,
you.
Nikki.
I'll just skip past this slide and then we can do a general questions if we've got a quick minute or two. But thank you so much to Lucy and Helen for presenting on your experiences of using co-creation. And thank you to everyone who has attended today to listen. If you want to learn more about co-creation or the Co-Creating Wellbeing project in particular, please do visit this website. I'll pop it in the chat at the end unless someone else has. I can't see the chat at the moment. Please also feel free to get in touch with myself, Gemma, Helen or Lucy if you have any questions. If we do have time for questions, I'm more than happy to answer them. I will skip to the next slide just because we do have a evaluation form that we would like people to fill in. So you can use a QR code or visit the menti.com website and use the code online. Has anyone got some really speedy questions? I think we have like 60 seconds left before 2 o'clock hits.
Right, thank you everyone. That was a really brilliant webinar, so thanks so much for your time, and thank you everyone for coming online to watch the webinar.